Welcome to Ask the Educator, a podcast brought to you by Healthmark Industries. Are you a sterile processing technician or manager? Maybe you work in infection prevention or biomedical engineering. Whether you're a frontline tech, endoscopy tech, or nurse, or surgical services administrator, you undoubtedly have influence in medical device processing at your facility. In each episode, we speak with experts from the Healthmark Clinical Affairs team, industry leaders, or special guests from the trenches to answer your questions and bring you relevant industry information, equipping you for excellence in medical device processing. My name is Kevin Anderson, and I will be your host. Now let's get started. Hey everyone, welcome back to the Ask the Educator podcast. This is Kevin Anderson, your host, and I have joining me my co-host, Adam Okada. Adam, you just wrapped up another one of our international webinars. This one was really good for me personally. I still consider myself a little bit of a newbie when it comes to understanding the depth and the breadth of all these different AMI documents. So talking with us on this podcast is the guest of honor from our international webinar, which is Ralph Basile. Ralph, thanks for joining us and agreeing to do the podcast right after the webinar. We're working you hard today.
It's a pleasure, Kevin. Thank you for inviting me.
Yeah. So just to get right into it, right? We just a quick introduction to what ST98 is and who it's intended for.
Yeah, good question. And it was interesting during the podcast that, not surprisingly, I'm sorry, the webinar rather, we had a lot of people from healthcare facilities and so I had a lot of questions like that. But ST98 really is meant for the device manufacturers. And what's different about ST98 than any other document we've had before this is it's actually focused in on what the manufacturer is required to do to demonstrate, to validate that, in fact, the instructions they're providing to the end user results in a clean instrument. And we've had documents that have talked about what should be in the instructions for use, like TIR 12 and ISO 17664 and other publications, but those are always referred to as the labeling instructions. Even the FDA document, their FDA reprocessing guidance document, it's about labeling. They do get in a little bit about what validation testing should be done, but not the way ST98 does. ST98 is focused on the validation of those cleaning instructions, the development of them actually, and then the validation of them, so that when that testing is over, the device manufacturer has demonstrated, in fact, their device is clean if you follow the steps that they lay out. So it's a document that's meant for device manufacturers. Now, big player in that is also testing labs, because device manufacturers, some of them actually have the ability to validate in-house. I'm jealous of them because they spend a lot of money and they have a lot of capability. But most device manufacturers, even the ones that can do some testing in-house, ultimately will go to an independent testing lab because they want the stamp of independence, right? And testing labs are experts in doing this kind of testing and getting testing and results and reports that the FDA will recognize and review. And so those are the two big groups that ST98 are aimed at. Now, the goal, of course, is that a healthcare facility is capable of producing clean instruments, medical devices that are ready to go on to that next step of processing. Now, when we're talking about critical and semi-critical devices, then we're talking about the follow-up processes would be sterilization or high-level disinfection. If we're talking about non-critical devices, so those devices that come in contact with intact skin or might not even touch the patient, then cleaning low-level disinfection, that might be the last step right in the process. But either way, no matter what the classification of device you're talking about, you need to demonstrate that the instructions you're providing actually do result in a clean device and ready for the next step in the process.
Yeah, and that's an interesting point you make about the manufacturers having to do that validation testing, because that's, essentially what's required of them, and actually giving them steps and things that you talked about in the webinar, analytes and things like that, specific things they need to look for. What are those key changes to ST98 that are going to help the user ends talk about when we're talking about manufacturer testing and all these things? What are those key changes to the document that will help us move forward?
Yeah, great question. So one of the you mentioned the word analyte, and I explained a little bit. It's hey, the first time I heard the word analyte, I had no idea what it was. I had to look it up. I had to Google it. And actually, when you look it up, it's the perfect word to use because it's a term used in chemistry, but it's what you're testing for, right? So what chemical or we used to, for the longest time, we said marker. We talked about markers, which, so protein's a marker, hemoglobin would be a marker. Those are the ones that are commonly used. So the big things is that, first of all, this test soil that you use should be clinically relevant. So you have to demonstrate that, in fact, the test soil you're using is simulates the soiling, the actual clinical soil that a device will come in contact with. And there's a lot of steps involved in that. And you're going to evaluate it based upon not just the composition of the soil, but then also how sticky is it, if you will, adhesive qualities. When it dries out, right? Does it dry out in a similar way to the soil on the device? From the standpoint of like, where does it flow on the device? All those things have to replicate what happens to the clinically used device. So that's one of the big innovations. And that the fact that you need to test for 2 analytes, that's a big deal. For a long time. It was, and again, that's for critical and semi-critical devices, but for a long time, it was just one marker. The other thing that's really important, and in a way, I wish I'd stressed a little bit more during our talk. The first thing is it's got to be visibly clean. And that's really stressed in ST98. So it's not like you just, we passed this chemical test. Yeah. No. If I look at it, is it clean, right? And that's the same thing in the healthcare facility. So that's some key changes. The biggest change, of course, is that it replaced TIR 30, which had no requirements. Now, a lot of people in industry did look at that document and also TIR 12 to a large degree. They did look at those documents as almost being standards, and they would cite them, but they didn't have layout requirements. ST98 does. It's now saying, hey, device manufacturer, you need to do this to demonstrate that the processes, the steps that are in your IFU will result in a clean device. That was the biggest, I would say, key change, is that, hey, now it sets out requirements. And then it's got a really nice informative annex that it steps the manufacturer through. Okay, we told you what you had to do. Okay, now this is sort of how you do it. And I think the annex, which happens in a lot of documents, actually, annex, I think, is much longer than the actual normative section, because the normative section, you go boom, 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 this do this, and then the guidance, that part of it, you go in the detail. And I did also mention, and it's really is true, when we were developing ST98, and I should have mentioned the 2 co-chairs for Work Group 93, but Newport Jane and Steve Turtell, they led us in that effort. At that time, I was the co-chair for Work Group 12, along with Damian Bird at the end, when we were working through that document. But we were all working together, and we had a lot of the same people that were together. So those 2 documents were developed in parallel, and we worked really hard as a team. And I mean, everybody, 50, 60 people that were on both groups, to not duplicate, not say the same things over again, but make sure they align. So TIR 12 is meant as a support document to ST98 as well. So the publication, TIR 12 got published about a year ahead of ST98, but the 2 were developed really in tandem. So I think that, I don't know if I answered your question, but that's
Oh, absolutely. Yeah. It sounds great to me as a former end user and a former user of these devices in the operating room. I know how terribly soiled and how they can be, and also how terribly difficult they can be to clean.
Yeah.
And hopefully this document will go a long way in helping solve this issue. I like the main goal of it. But in your webinar, you talked about worst case scenario and using that as a methodology of performing these validations. And of course, Adam threw in the flexible reamer worst case scenario. And I just
Yes.
talked to him before we started this about a worst case scenario I ran into with bone cement. But
yeah, bone cement. Yeah.
but
yeah,
I'm
right.
just curious, what exactly does this mean?
Well, I'm not going. Yeah, flexible reamers are really difficult to clean. So that's a great example of a really challenging device. So, and that was this worst case. And I can tell you, having worked on a bunch of these documents, trying to describe worst case, because I'll give you an example. Okay, worst case would be you're running the automated washer has a cycle, and let's say it's got 2-minute pre-wash and 4-minute enzymatic, and then 2-minute wash, and then thermal disinfection for rinse or whatever for a period of time. And it gives you maybe a range, or the device manufacturer gives you a range of times, right? And you have to test the shortest time. The cleaning agent manufacturer might say give a concentration, right, between 1 ounce to 3 ounces. You need to test at that 1 ounce. That would be the worst case. So let me tell you, and I know I'm talking to people who are out in the field all the time, but I can remember going into a facility and looking at a washer disinfectant. We were not even there for that purpose. We just happened to be there. I was there with your colleague, Steve Kovac, right? We were there for doing in-service on something else. And we're looking at this washer, and there's this water shooting out where the spin arm is supposed to be. And that's what I need. The spin arm was supposed to be there. Okay. Is that worst case? Okay. For a device manufacturer, you're not expected to that might be real world, but that's, you're not expected to misuse. That would be an example of misuse, right?
That's a great distinction there.
Yeah. So worst case is the worst case in what you'd expect in a call sort of normal use or clinical use. And it is a gray area. I think the device manufacturer ultimately has to basically justify why they've defined worst case the way they have, but it's based upon the clinical use of the device, and then it's a little bit easier when we talk about sort of the cleaning, because you just talk about the lowest concentration or the lowest temperature or those kinds of things. But it's a gray area, and it's really important, as I mentioned in the webinar. Hey, as a device manufacturer, I'm not going to give you in the IFU the worst case, right? I'm going to recommend the best scenario, or scenario that's most likely to achieve the goal, but I have to have tested it. So it's going to be the same steps, but I might recommend 2 ounces per gallon, rather than 1 ounce per gallon, because I know your chance of being successful is even greater at that. But that's in my IFU. That's not in the validation testing.
And you said it in the webinar. You gave a lot of great examples of what worst case could be. For example, delayed processing. If several hours go by and the soil is allowed to dry, that would be an example of a worst case that the manufacturer would have to test for.
Yeah, and that survey question, I really like. I think we got about 40% of the people said that. And of course, having spent a lot of times in hospitals, you just know that the stuff. Okay, you don't even know how long it sat in the OR. Then it comes down, and everything arrives in SPD at the same time. And you only got 3 machines and a certain number of people, so stuff just sits there. And I think what we are seeing is device manufacturers are extending that dry time in their testing. It used to be like 1 or 2 hours. I'm not saying some might not even do that, but you're seeing a lot of them extend it to maybe 8 hours. So it's a whole shift, or maybe overnight, or some may even test to 72. Considering a facility that maybe is closed on the weekend. So they're going to come after me. You might, the device manufacturer has to justify how they define worst case. So, but yeah, great example, Adam.
And I think that's ideally, that's what we're talking about with these worst case scenarios is this is what's happening in the real world. So manufacturers should also be testing for things that are happening in the real world. And, ideally, what do you think the effect of ST98 is going to have on the industry? Because I see a lot of positive things. If we can have manufacturers be actually testing the cleaning of their actual devices for actual soils or simulated soils that are simulating what you're seeing inside the facility should be able to clean to these IFUs. It shouldn't be this kind of thing where we're like, how did the manufacturer ever think this instruction was acceptable? It shouldn't be that anymore, right? This should ideally move us toward a direction where it's moving the industry forward.
Yeah, that's really well said. That really is the goal of ST98 and some of these other documents that I mentioned as well, is is to improve things. I mean, ultimately, right, our goal is patient safety, patient outcomes. I mean, and we talk about this all the time, right? We're all the patient. so I mean, we're all going to have procedures done on us and have had procedures done on it. And we want instruments that are clean and safe to use and ready to use, and we have family members, et cetera. So yeah, ST98 is setting a new bar for the industry that's not been there before, and it's really providing requirements now, and there weren't requirements before. So if you're a manufacturer and you're claiming compliance to ST98, as I mentioned during the webinar, you get audited by your ISO auditor, and you're not following ST98. Ding, ding, and it could be a major finding. So I think it'll help us all improve. And there are other things in process we're not done. There's more to do. As you guys know, there's always opportunities to make things better. It's job security for the three of us, I would say. So.
That's right. And I think that's a great place to wrap it up. And Ralph, I thank you for sharing your expertise. You've got so much experience with Auntie Amy and on all these different working groups. And it's just always great to have you on to explain this stuff, because as you know, a lot of the folks out on the front line, they don't have the same type of exposure to these documents and to what's going on. And a lot of times I think that they have some sort of misconception sometimes about what it is these groups do. And I think this one is really one that is going to try and help them out a lot. So I just thank you for your time, for sharing about this. And I wanted to mention as well, if you guys are listening to this, please go check out the full-length webinar. It's on the hmark.com website under the Education tab. Check it out there and sign up for future webinars as well.
Yep. Thank you, Kevin.
All opinions expressed on this show are those of the presenters. Before using any medical device, it is important to review the device manufacturer's instructions for use.